Hello, guys. Today we are going to cover the topic of hypertension, which is a very high yield topic in the cardiology section for AMC MCQ exam. So, for hypertension, we are going to cover some certain topics and management approach through the eTG guidelines. We are going to study different types of hypertension and the management of hypertension and hypertensive emergency and urgency and the complications associated with hypertensive emergencies. So, starting with that, we have first let us understand what are the different types of hypertension. First of all, we have primary and essential hypertension, and it is the most common cause of hypertension, and it is present in 90% of the cases present with primary essential hypertension. So, it is actually the persistent raised blood pressure of more than or equals to 130 by 80 with no identifiable cause. So, you have to know that there are no identifiable cause in the case of primary or essential hypertension, and the patient would complain of this kind of hypertension would be of gradual onset. The patient would be of middle age, and the risk factors for this essential hypertension are increased age, obesity, high salt intake, alcohol intake, increased alcohol intake, inactivity, and the patient has family history. So this is the first diagnosis, and this is the diagnosis of exclusion. That is the essential hypertension. Then we have the secondary hypertension. Secondary hypertension is actually from the specific or any fixable cause. And this We are going to suspect secondary hypertension when the patient is usually young or older, has a young or older onset, and the blood pressure is very high, and it was sudden in onset, and it is very severe, and also resistant to two or three hypertensive drugs, three hypertensive antihypertensives. So we are going to suspect secondary hypertension. So we have a mnemonic, a specific mnemonic, that is CHAPS. With the mnemonic of CHAPS, you can remember the causes of secondary hypertension. For C, we have Cushing syndrome, H for hyperaldosteronism, A for aortic coarctation, P for pheochromocytoma, and S for stenosis of renal artery. So the treatment of secondary hypertension is actually treat the underlying cause. So there are certain keywords, that is, if the patient has hypertension and hypokalemia, you are going to suspect primary hyperaldosteronism. If the patient has the BP that is raised in the arm more than legs, so it is the aortic coarctation. And if the patient has episodic hypertension and the history of headaches and sweating and diarrhea, that would be we are going to suspect pheochromocytoma. Then we have a very important kind of a hypertension, that is urgency or emergency. So hypertensive urgency is actually the raised BP of more than 180 by 110 with no acute organ damage. On the other hand, in the case of emergency, there is a hypertension of more than 180 by 110 with acute organ damage. So the treatment of urgency would be oral medicines over 24 to 48 hours. On the other hand, in the case of emergency, hypertensive emergency, we are going to normalize the BP through IV drugs, and there is a controlled decrease in blood pressure in the first hour. So we are going to discuss it later in the second part of the video, the hypertensive urgency and emergency, the severely elevated blood pressure. Then we have the isolated systolic hypertension. It is usually present in older adults with high systolic blood pressure, but they have normal or low diastolic blood pressure. And it is the most common hypertension pattern in elderly patients. Actually, the mechanism is the stiff arteries that have lost their elastic recoil with age. So it is the cause of isolated systolic hypertension. Then we have the resistant hypertension. Resistant hypertension is actually when the BP stays above the goal despite three drugs at full doses. So if the question comes to you as the patient has already been given three antihypertensive drugs, so what should you do next? So first, we have to make sure that those drugs were given at the full doses. So it is important that the BP for resistant hypertension to get diagnosed when the BP stays above the goal despite three drugs at full doses. and one of which is diuretic. So, three causes can come to the mind if the patient has poor adherence, or is the patient is taking too much salt, or is there any missed secondary cause of hypertension that has to be ruled out or that has to be diagnosed. So, these were the types of hypertension. Now, coming towards the management of hypertension. So, when are we going to start the BP lowering drugs? So, if the patient has significantly elevated BP, that is systolic BP of 160 or more, or diastolic BP of 100 or more, and there is the established ASCVD, atherosclerotic cardiovascular disease risk, or high or intermediate atherosclerotic cardiovascular disease risk. If these risks are present and the elevated pressure is significantly high, so these are the indications for BP lowering drugs to get started. But if the patient comes to you with elevated blood pressure, but it is not significantly raised, and he do not have any comorbs like he do not have any cardiovascular disease risk factor, so we can the first line management would be the lifestyle modification. But if the patient have any of these, we are going to start the BP lowering drugs. So first of all, we have the non-drug management of raised BP. Non-drug management of raised BP is actually the lifestyle modification that includes the regular aerobic exercise, decreased alcohol intake, moderate sodium reduction, healthy eating. Weight reduction is very important because 5 kilograms of weight loss can reduce BP by 7 by 3 millimeters of mercury. So weight reduction is very important, and the most important lifestyle modification that can correct BP. Then we have the another risk factor is the obstructive sleep apnea, and it is the strong independent risk factor, and the management of this condition can reduce the BP. Then we have the drug therapy. So if the patient has uncomplicated hypertension, and he in non-pregnant adults, the first line drugs are ACE inhibitors, ARBs, dihydropyridine, calcium channel blockers, thiazide or thiazide-like diuretic. So some important points. There are some important points we have to keep in mind before starting the antihypertensive drugs. So before starting the drug therapy, we have to confirm that elevated BP is not secondary to treatable cause. And the combination therapy is more effective when we are starting the antihypertensive treatment. So combination therapy is effective and has less side effects. So the changes to drug therapy are considered after the 4 to 6 weeks of starting therapy, and adding a low dose of second drug from different class is more effective than increasing the dose of the initial drug. For example, if the patient is on monotherapy and he is not getting controlled his hypertension, his blood pressure, we are instead of increasing the dose of that alone drug, we are going to add the low dose of second drug, because the combination therapy is always more effective and has decreased side effects. So you have to keep that in mind. And if the patient is and if the blood pressure of the patient is not getting controlled, first we have to check the adherence, non-adherence or secondary causes before adding the third drug. Now, there are certain combinations that we have to avoid when we are giving antihypertensive, especially when beta blockers and rapamycin are avoided, and they are not given in combination because they can cause heart block. And ACE inhibitors diuretic. When the patient is on these two drugs, NSAIDs are avoided because they can cause acute kidney injury. Now, starting with our antihypertensive drugs. So, first line drugs include ACE inhibitors, ACE or ARB, dihydropyridine, calcium channel blockers, and thiazide diuretics. So, ACE inhibitors and ARB inhibitors, they are indicated when there is increased BP and the patient has heart failure with reduced ejection fraction. Chronic kidney, the patient has chronic kidney disease, especially diabetic nephropathy, or the patient is on long term therapy after MI. So, ACE inhibitors are the first line drugs. What are the side effects or contraindications? Creatinine and potassium can temporarily be increased when we are giving these drugs, and they subside by the time. These drugs are contraindicated when the patient has bilateral renal stenosis, and we have to avoid ACE inhibitors and ARBs when there is a history of angioedema. Then we have dihydropyridine calcium channel blockers that are amlodipine and nifedipine. They are indicated when there is increased BP plus stable angina. And if the side effect of these calcium channel blockers are the peripheral edema. If it does not subside, peripheral edema does not, if it does not subside, we have to decrease the dose of calcium channel blockers or stop these drugs. Then we have thiazide or thiazide like diuretics. They are indicated when there is uncomplicated raised BP in more than 65 years of age, and it is not recommended as first line in young adults because it can cause new onset diabetes, and it is also contraindicated in gout. So these are the first line drugs, and they can be given in combination therapy. That is, the two drugs can be given. Then we have the second line drugs. When we have to add the third BP lowering drug, we are going to add it from the second line drugs. In second line drugs, we have potassium sparing diuretic, that are spironolactone and amyloid, and these can be added on the first line drugs. And if after prescribing, if after taking the potassium sparing diuretic, the BP normalizes rapidly, it indicates the primary aldosteronism. Before giving potassium sparing diuretic, we have to check the kidney function and potassium concentration first, because it can increase the potassium levels. So if potassium is 5 or more, we have to avoid these diuretics. Then we have beta blockers. Beta blockers are given when there is increased BP plus first line. They are also given as the first line drug for to prevent the stable angina. So if the patient has a history of a stable angina, and he also have the history, he also gets raised BP. So beta blockers would be first line. Beta blockers can be given in this case because for stable angina, beta blockers are the first line drugs. After MI for 12 months, beta blockers are prescribed, and for heart failure with reduced ejection fraction, heart specific beta blockers can be given. And the side effect of beta blockers is that it cannot be stopped suddenly because it can cause rebound sympathetic effects that are raised BP and increased pulse, that is tachycardia. Then we have alpha blockers. Example is prazosin. And if the male patient has BPH or symptoms of BPH and he has increased BP, the alpha blockers, that are prazosins, are considered. And the side effect of alpha blockers are that it increases the rate of cardiovascular events, and it is also associated with the postural hypotension. So alpha blockers are associated with the postural hypotension. This is the side effect of alpha blockers. Then we have non-dihydropyridine calcium channel blocker, that is verapamil or diltiazem. It is indicated when there is increased BP and stable angina. It is contraindicated in left ventricular and significant systolic dysfunction. So non-dihydropyridine calcium channels blockers would not be given in this case. Then we have centrally acting alpha 2 agonist, that are methyldopa, monoxidine, or clonidine. If the patient has increased BP and she is pregnant in pregnancy, so the centrally acting alpha 2 agonists are given. Monoxidine is contraindicated in the case of heart failure, and in case of clonidine, we do not stop clonidine suddenly because it can cause rebound hypertension. Then we have direct acting vasodilator, that are minoxidil and hydralazine. These drugs are used when all the other drugs have not been able to control the blood pressure, and those were not tolerated. So hydralazine and minoxidil are considered. With minoxidil, there is a side effect of fluid retention. So with minoxidil, diuretic is given to prevent the fluid retention. And also there is a risk of tachycardia. So to prevent tachycardia with hydralazine, we also give the beta blocker to prevent tachycardia. So this was the management of hypertension. In part 2, we are going to do the severely elevated blood pressure, that is hypertensive emergencies, hypertensive urgencies, and the complications associated with them, and the management of those conditions. So thank you for watching.